Good evening, everybody. Welcome to today's classroom series. Today's topic will be discussed by Dr. Rajeeb, sir. The topic is early brain injury in aneurysmal subarachnoid hemorrhage. So, there are a lot of discussions about vasospasm and everything, but what is more important is the early brain injury and how we can manage it. So, over to you, sir.
Thank you, Dr. Sindhu. And first of all, I would like to thank the organizers of NCSI for inviting me to talk on this topic. I will be dealing a very specific entity called as early brain injury in patients with subarachnoid hemorrhage. Most of our focus in clinical care practice or neurocritical care is on vasospasm and delayed cerebral ischemia. But our focus should be on the acute phase of the aneurysm when within 3 days, whenever they present, we should take care of the acutely injured or the insult of cerebral insult. So today my talk will be under the following outline: the what is the importance of early brain injury, so, how to define early brain injury? So, what are the etiopathogenesis revolving around how early brain injury happens? Implications for clinical practice. After knowing all the theory and pathogenesis about the early brain injury, how can we manage? What all we can do? And what are the future strategies pertaining to the early brain injury management? So we all are aware of the CONSCIENT trials. There are three CONSCIENT trial, 1, 2, and 3. They have all used clazosentan, that is a anti-vasospastic drug, acts against endothelin receptor 1. So in endovascular coiling patients, they have given this drug, thinking that vasospasm would improve. However, they have seen improvement in vasospasm, but not vasospasm-related outcomes. Why is so? So there are so many other theories, mechanisms. That is how the DCI was conceptualized back in 2012. However, there are other mechanisms also. For example, the early brain injury itself. If we cannot treat the early brain injury in the beginning, if you treat vasospasm, if you treat DCI also, it will not be helpful later. So, what is early brain injury? It is nothing but the immediate brain injury occurring after aneurysmal subarachnoid hemorrhage. It was first reported by Kusaka et al. In 2004. Over the last decade, focus has been shifting towards this early phase. So, the term EBI has been coined as the period in which the injury to the brain spans from the moment of initial bleeding to the onset of cerebral vasospasm. So if you see this chart, first 3 days up to 72 hours, in some literature they go up to 96 hours. This is the phase of early brain injury. And after the early brain injury, the phase of vasospasm and DCI begins. So what is the incidence of early brain injury? Is it a significant problem that we are addressing? If we see a dichotomous variable, for example, presence or absence of edema in CT scan, we see the early brain injury to be 8% on admission and 12% after admission. However, when we apply some semi-quantitative measures of SH, EBI detection, early brain edema score detection, for example, the incidence becomes 49%. Quantitative measurement of selective sulcal volume, if we do, that will become 61%. So the incidence of early brain injury is more. And the modern imaging has proved that the prevalence of early brain injury in during this first 72 hours remains high. Why it is so important? Also because the interlocked etiopathogenesis with DCI, and subsequently it will lead to poor outcome. The common denominator to DCI and long-term morbidity mortality is the early brain injury. So we have to know what is the definition of early brain injury. However, the definition is not very straightforward, simple. It has been used in heterogeneous clinical settings. It depends on the clinical symptoms. It is based on the neuroimaging parameters and based on the advanced monitoring used. So a clinician will consider early brain injury if the patient is having a poor grade aneurysm, defined by Hunt and Hess scale of 4 and 5, WFNS 4 or 5. And in presence of ictal loss of consciousness, presence of neuroworsening. All these things are clinical symptoms which tell us the patient is having early brain injury. Neuroimaging wise, if there is intracranial blood burden, global or focal cerebral edema, more ischemic lesion load, then also neuroimaging wise, this is early brain injury. If we are measuring the substrate extracellularly in the brain, so brain tissue oxygenation, metabolic distress, excitotoxicity, mitochondrial dysfunction, axonal injury, and spreading depolarization, all these are in the phase of early brain injury and they define early brain injury. Similarly, inflammation, neurohemoinflammation, systemic inflammatory response, they also define the early brain injury. So, early brain injury definition is not very unique, it is heterogeneous, includes all these things. What are the clinical conditions which are not considered early brain injury? First one is early obstructive hydrocephalus that can mimic severe SH, which will improve after placement of EBD. It is not considered as early brain injury. Early onset seizures can also mimic the early brain injury. However, it is not considered as early brain injury. However, here uh, one should be knowing that both of these conditions, if not managed, can aggravate the early brain injury. The pathogenesis of early brain injury is a myriad of pathogenesis happens. One is the neuroinflammation. Here, as early as within 4 to 5 minutes of bleed, there can be leukocytic infiltration, microglial activation, which can lead to further inflammatory product and cerebral edema. Apoptosis and neuronal death starts as early as 4 to 5 minutes of the early subarachnoid hemorrhage bleed. Microcirculatory dysfunction starts due to decrease in nitric oxide and increase in intracellular calcium concentrations. Cerebral edema, which is seen mostly uh, as a part of the early brain injury, towards the end of the early brain injury, is always a mixture of cytotoxic and vasogenic edema. Oxidative cascade, which are seen because of the elevated metabolic demand in the early part of the injury, and it overwhelms intrinsic antioxidant system. Blood products can cause lipid peroxidation, which can worsen free radical generation, which can worsen the situation. So it can lead to early brain injury. Blood brain barrier disruption can also happen due to the different metalloproteinases, matrix metalloproteinases, which can degrade the basal lamina, which can lead to loss of tight junctions, degradation of matrix, which can be leaky capillaries, which can lead to brain edema, and it can happen as early as 30 minutes of the initial ictus. So the mechanism is vast. There are several molecular targets involved in this mechanism, which can be potential therapeutic options later. Another important mechanism here is the axonal damage. It not only affects the gray matter, but also white matter is affected. Axonal damage can be seen and demyelination can be seen. And it is a part of early brain injury. And another important concept associated with EBI is the spreading depolarization. We must have heard the term cortical spreading depolarization, which is always associated, most of the time is associated with acute brain injury situations. In subarachnoid hemorrhage, we have read about spreading depolarization in DCA, pathogenesis of DCA. However, it can happen as early as after 1 day, 24 hours or 4 to 48 hours of injury, subarachnoid hemorrhage. So this is a very beautiful pictorial representation of cortical spreading depolarization. Here in the above picture, first half of the picture, one can see normal hemodynamic response to the spreading depolarization. If you can see, there are electrodes 6, electrode 4, electrode 6, electrode 4. These are all electrodes from the subdurally placed grid electrodes over the cortex. So here one can see there is a depolarization wave starting, which gets carried to the electrode 4 that is depicted in red color, and the delay is 633 seconds and the velocity of transmission is 1.9 millimeter per minute. This is usually typically the velocity of propagation of the cortical spreading depolarization. Similarly, in the ECOG recording, one also can see a depression or the change in the firing potentials of the neurons from this blue point to the red point in electrode 4. However, if we put a laser Doppler flowmetry, here we can see regional cerebral blood flow which increased with the spreading depolarization, also propagated with it in a similar fashion. So this is a normal response to the spreading depolarization. This can be seen in healthy individuals also. This may not be detrimental because of the flow metabolism coupling, the flow increases because of the depolarization. However, inverse hemodynamic response, which is called as spreading depolarization or spreading ischemia, is detrimental. Here one can see the inverse relationship between the spreading depolarization and the blood flow obtained from the laser Doppler flowmetry. This is more detrimental and this can cause subsequent ischemia, and further, if not treated, it can lead to infarction. So, in subarachnoid hemorrhage patients, there is a new concept, relatively new concept. It's called as ferroptosis. It is nothing but an iron-dependent programmed cell death. So morphologically, it can be that we can see shrunken mitochondria, increased mitochondrial density, mitochondrial outer membrane rupture, and this triggers reactive oxygen species accumulation in the cytosol. And this has been proven that iron chelators and antioxidants such as ferrostatin and vitamin E, all these things can elevate the EBI associated with SH due to the inhibition of ferroptosis. Although it has been proven in vitro models uh, and in experimental subarachnoid hemorrhage models in mice. So, having said all of that about the pathophysiology, pathogenesis of early brain injury, we have to diagnose, we have to know whether it is happening or not. The best modality here is the imaging. In imaging, CT brain and MRI brain are the options we have. In CT brain, what we can find is global cerebral edema. There is a scoring system, which is a semi-quantitative scoring system, subarachnoid hemorrhage early brain edema score, and selective sulcal volume assessment, which is more quantitative assessment of the edema. So in this picture, one can notice there are 4 cuts of CT scan at different levels. So A and B depict the scans of a single patient, and C and D depict scans of a second other patient. So in A and B, we can see the differentiation of gyri and sulci at 2 levels are lost. One is at the level of centrum semioval, that is above the level of lateral ventricle. Another is at the level of insular cortex, showing thalamus and basal ganglia. In these 2 levels, we cannot clearly differentiate which is sulci and gyri. So the scoring has been given as 1, 1 both sides, and in upper cuts also 1, 1 both sides. So total score is 4, and this is called as the highest Sebis grading scoring. So Sebis grading starts from 0 to 4, and 4 being the highest. In the second picture, C and D, in the second patient, one can differentiate some amount of sulci differentiation on the right side at the level of insular cortex. And on the left side, we cannot observe any differentiation. So score of 1 was given. Similarly, in the upper cord, above the level of lateral ventricles in the circumsemioval cuts. Similarly, on the right side, we can see some amount of differentiation is preserved. So score of 0 was given, and 1 was given for the score of 1 was given because of the lost effaced sulci. So this score is 2. So the difference, 4 is the highest score, and 2 is the in this patient the score is 2. So in this study, the Sebis score has shown that predictor of high Sebis score is due to these clinical variables, and mostly loss of consciousness ictus has shown a very high chance of high grade SEBI score. Selective sulcal volume assessment, how it is done. If you see in this figure, we can see there are three patient. One is patient A, patient B, and patient C. In patient A, on the left side of the figure, we can see there are absolutely or difficult to differentiate the gyri cell site differentiation in both the levels, and also we cannot see any sulcal pattern there. However, in figure B, we can see some sulci and which are labeled as a green color in this selective sulcal volume assessment. And in figure C also, we can see a better sulci pattern and they are very well labeled. So panel A shows a global cerebral edema with a SEBIS score of 4. I can give a score of 4, 1 on this side and 1 also this side. And a selective sulcal volume assessment which was done automatically by the software, which will tell it is very much low. Here it is 0.03 ml. And in figure B, we can see some differentiation and the SEBI score is 2 here and selective sulcal volume is 28.5 ml. And in figure C, the score is 0, SEBI score, very good. There is no edema, so very good appreciated sulci we can see. So score is 0 here. And the selective sulcal volume is also high. So it has been studied that a selective sulcal volume of less than 5 ml is associated with very poor outcome in these patients. So next imaging is MRI. MRI brain can tell us about the ischemic load, cytotoxic or presence of vasogenic edema and axonal involvement. So the usefulness of MRI is due to the use of diffusion weighted imaging in these patients. And in diffusion weighted imaging, we can see hyperintensity, and on ADC maps, it will be hypointense. So this is one of the definition taken in one study, and they found an overall incidence of EBI to be 27.3% in their cohort. Whereas with a high grade SH like WFNS 4 and 5, it was 45% the incidence of EBI according to their definition. And mostly it was observed more in the frontal lobe, paramedian frontal lobe. However, there are several types of pathology in EBI involved. It can involve symmetrical cerebral cortex. It can also involve focal cortices and periventricular area. Another MRI-based study in the acute phase within 72 hours was done, which shows a mixture of early cytotoxic as well as vasogenic edema due to DWI and ADC calculation. It was not only seen in the cerebral gray matter, also seen in the brainstem and cerebellum. So MRI tells us the involvement of cortical gray matter as well as the axonal and white matter. So other modalities which can be used is invasive neuromonitoring, which can be cerebral microdialysis related lactate pyruvate ratio, glutamate and glycerol, which are all elevated in the first 72 hours. Neuroinflammatory markers, for example, CSF interleukin 6, elevated levels of matrix metalloproteinases can be observed in these patients during these periods. So now we know about little bit of etiopathogenesis of this EBI, little bit on diagnostic tools and monitoring modalities. Then what is the implication of EBI in our clinical practice? We have to first know that EBI is a form of secondary brain injury that occurs after the primary insult to the brain by the subarachnoid hemorrhage or the bleed. However, currently there are no specific therapy available, only targeting the EBI. However, the primary aim still remains to maintain the energy supply to the brain and normalizing the parameters which can aggravate the EBI. So we have to stick to our basics while managing the EBI. So the ICP control, if the ICP is elevated, we have to control the ICP, optimize the cerebral perfusion pressure, manage the global cerebral edema, targeted temperature management, intracellular, if there are intracerebral blood burden. We have to help in clearing the blood burden and aneurysmal treatment, management of spreading depolarization, management of seizures, and management of neuroinflammation. So let us consider first is ICP control. In our setting, we always see if the patient with aneurysmal subarachnoid hemorrhage with lot of intracerebral blood burden, IVH, acute hydrocephalus, all these things are there, then there is a chance that the patient will have high ICP. So in those patients, we have to maintain normal ICP or control the ICP. The ICP raised above a certain threshold is more important than the absolute values. And the ICP burden is always related to the poor prognosis in these patients. So we have to apply the general principle, optimizing ICP, position should be optimal, ventilation strategies to maintain normocapnia or short-term hyperventilation can be tried, acute sedation and analgesia should be good, surgical hematoma evacuation in case of mass lesion, osmotherapy often used, but the outcome is not good always. How to optimize CPP? Is it a distant dream in subarachnoid hemorrhage? Optimized CPP should be done in different phases of the subarachnoid hemorrhage. A higher CPP target of more than 70 may decrease the brain tissue hypoxia and metabolic distress in poor grade SH patients. Cerebral autoregulation impairment is seen in the early phase of the SH. However, it is individual specific, the variability exists in cerebral autoregulation. There was a trial in a TBI patient which was called as cogitate trial. Here, individualized CPP target based on the autoregulation status was done. And it was feasible and safe. So the question remains, can it still be applicable to aneurysmal subarachnoid patients in the early phase? So the management of global cerebral edema. Limited literature is available for this. And this is the study from the Sebius authors where they could find 1 point increase in Sebius grade is related to increase in DCI by 2.24 times and unfavorable outcome by almost 3 times. So that means we have to treat the global cerebral edema at any cost. So the aim remains to meet the brain energy supply demand. CPP more than 90 sometimes can be helpful to improve the brain metabolism. Hypothermia can be a potential option. However, current recommendations do not follow hypothermia. Targeted temperature management should strictly be followed. So what is targeted temperature management? Up to 60% of the critically ill patients, brain injured patients experience fever during 24 hours of their admission. Normothermia is currently recommended, although no high-grade evidence is there in support of this. Another study, ongoing study, is their INTERPID study, where in acute brain injury, including SH patients, they are planning impact of normothermia on functional outcome. Coming to the intracerebral blood burden and aneurysmal treatment. Aggressive neurosurgical clearance of blood resulted in conflictive evidences. However, a recent study published in JAMA Neurology 2023 suggests that placement of lumbar drain along with the standard care achieved good success in achieving good outcome in these patients, which was statistically significant as compared to the standard care group. So that is why active management should be done. Active management should be done to clear the intracranial blood burden. Management of cortical spreading depolarization. It remains challenging because diagnosing cortical spreading depolarization requires placement of subdural or cortical electrode placement, which again remains invasive and challenging. However, there are certain drugs like ketamine which can dose dependently suppress the cortical spreading depolarization. Similarly, hypothermia can also suppress the cortical spreading depolarization. Nimodipine has been shown to reduce or suppress the spreading depolarizations. However, in practice, normothermia and normotension and providing sufficient energy to the brain are recommended. Definitely, seizure has to be managed. Anti-epileptic therapy should be initiated in the patients who are having seizures. However, prophylactic use is not recommended in these patients. Management of neuroinflammation. So, from the ages, people are trying different anti-inflammatory agents, for example, steroid and nitric oxide donors, but these are not helpful in improving the outcome. However, recent studies show some promising result from experimental models in animals where use of fluoxetine high doses, isoflurane, sevoflurane, and use of dexmedetomidine had shown to be promising in treating the inflammation. So this is a study in showing the levels of brain extracellular interleukin 6 in patients with subarachnoid hemorrhage. They studied after infusion of diclofenac, the levels of interleukin 6 in the brain extracellular measured by the cerebral microdialysis decreased gradually. So this can be a potential option, use of diclofenac in preventing early brain injury and then subsequent DCA and poor outcome. This is a study of isoflurane versus sevoflurane for EBI in experimental subarachnoid hemorrhage patients. This is done in lower primates and mice model of experimental SH. 2% isoflurane and 3% sevoflurane were given for 1 hour after SH induction within 60 minutes of SH induction. So they noticed that this can reduce the neuronal apoptosis, blood-brain barrier dysfunction, and brain inflammation through sphingosine-related pathways. So they suggested 2% isoflurane and 3% sevoflurane are neuroprotective. Both are effective against early brain injury after SH. They can suppress SH-related apoptosis and brain inflammation. So these can be a potential. This can be potentially tried in patients. However, human trial or translation to the human practice has not been done. Use of non-steroidal anti-inflammatory drugs in the pathophysiology of vasospasm and subsequent DCI has been done. And there is a critical review where it states that inflammatory cerebral changes which can contribute to the development of EBI can be ameliorated by using the NSAIDs. They are even more effective in reducing vasospasm than nimodipine. This critical review states like that. So how they are effective? They are effective at various levels. One is at brain parenchyma, one is at vascular smooth muscle, and they can also affect at endothelial cells. In brain parenchyma, they can inhibit COX-2 pathways, and following inflammatory brain damage can also be halted. In vascular smooth muscles, they can also affect the voltage-gated calcium channels, which can cause vasoconstriction, is now prevented after giving NSAIDs. In endothelial cells, again mediated by COX-2, and they can release and decrease the inflammatory mediated release. So what are the future strategies? So future research should focus mainly on early brain injury by integrating brain-derived biomarkers. In this regard, there can be methods to estimate CSF biomarkers as well as blood biomarkers. One of the example I have shown is interleukin 6, matrix metalloproteinases. Other examples could be endothelial damage products like syndecon 1, heparan sulfate. All these things can be obtained from the CSF or blood itself to diagnose or to predict the occurrence of EBI and predict the occurrence of DCI in the future. Further studies are needed to clarify the exact mechanisms involved, We have discussed a whole lot of mechanisms which are involved in early brain injury. However, none of the studies which pinpoint to a particular uh, exact mechanism which can lead to early brain injury and treating that will ameliorate EBI, it is not there. Further clinical studies should aim the possible molecular targets to limit the EBI progression. So, in conclusion, we can say that EBI is a multifaceted secondary brain injury with heterogeneous etiology. Recent advances in imaging identified a very high prevalence of EBI. There is always the therapeutic window or the margin is very narrow. Before the onset of DCI, within the 3 to 4 days, we have to act swiftly and prevent the progression of EBI so that DCI can be prevented. Currently, active trials are focusing mainly on DCA and vasospasm. However, the therapeutic molecular targets of the EBI are neglected. So, more and more research is therefore required into the acute changes in the cerebral homeostasis occurring in the first 72 hours of subarachnoid hemorrhage. With this, I conclude. Thank you very much. Over to you, Dr. Sindhu.
Thank you, sir, for this very informative session. Sir, I just have one question for you. Like you said that we have to remove the blood from the brain as much as possible, whatever has spilled out. So, what about the blood in the ventricles, sir?
Yeah, that's
Like,
what I showed a study of lumbar
yes,
drain uh,
yes,
recently published in JAMA 2023. There they have placed lumbar drain as well as EVD was placed in patients where it was required. Lumbar drain was additional. And with the presence of lumbar drain, the outcome, 6-month outcome measured by the MRS scale was good. So
oh,
that's what
that's
they are saying. They are reiterating the fact that if we aggressively remove the blood, intracranial blood burden, be it intraparenchymal hemorrhage or be it intraventricular hemorrhage, the outcome is better. And within the initial first 72 hours only, they started the management. They have treated the aneurysm within 48 hours of the patient admission. Also, the lumbar drain was placed within the first 3 hours and continued for 8 days. This is how we have to reduce the blood burden.
so sometimes the EVD has got, I mean, there'll be the blood stain secretions which are coming out. Sometimes the EVD gets blocked. So, what do you feel about giving intraventricular urokinase or streptokinase to just dissolve those blood clots, sir?
Yeah, it has been tried also previously. However, studies are not the results of the study. They do not favor any good outcome. It has been done use of streptokinase, urokinase intraventricularly to dissolve the clot, so the EVD drainage or output increases. However, the outcomes have not been shown to be a
All
favorable
right.
outcome. Thank you.
So, sir, so in a nutshell, we just have to act very fast, maintain cerebral blood pressures, I mean, provide anti-inflammation, maintain the temperature and the electrolytes well to improve the outcome of the patient. And we have a very, very short duration of probably just 1 or 2 days, maximum of 3 days to prevent the early brain injury. So that is what is important about this topic. Thank you, Rajeeb sir. Thank you for this extensive and information which you have provided us. Thank you so much, sir.
Thank you very much.
Thank you, sir.